everyone. I work at the Pediatrics Center at Semmelweis University. My supervisor is Miklós Garami and my SMS is now Mahmoud Obeidat. My vision is to improve the life quality and extend the life expectancy of children treated with central nervous system diseases like malignancies and hydrocephalus, and I would like to provide guidelines for the treatment of these diseases. I've got two specific goals. The first is about antibiotic-impregnated ventriculoperitoneal shunts, and the second is about targeted therapies. So a bit about the background. So 1 in 500 to 1 in 1,000 babies are born with hydrocephalus, but hydrocephalus can be also secondary due to various causes like hemorrhage, tumor, infection, and trauma. Ventriculoperitoneal shunt is the most common treatment for this condition. Our problem is that the incidence of infection is still unacceptably high. It's between 3 and 20%, which can cause 2 times higher mortality, cognitive impairment, and a lot of invasive and expensive procedures. So our aim was to compare the rate of bacterial VP shunt infection with and without antibiotic prophylaxis. We included all the patients, so also adults and children. And here the antibiotic prophylaxis was an antibiotic-impregnated shunt, which was impregnated with rifampicin and clindamycin. And we hypothesized that the rate of bacterial infection decreases with this antibiotic prophylaxis. I conducted my systematic search 1.5 years ago. I was looking for articles in 4 databases. And first I had more than 10,000 hits, and after I got 27 full eligible articles. 4 of them were randomized control trials, and the others were like retrospective cohort studies. This is my main forest plot, which is about infection in mixed populations. So all the 27 articles are included in this forest plot. And the measure of effect was odds ratio. If the odds ratio was below 1, that meant that antibiotic-impregnated shunt has a protective factor against bacterial VP shunt infection. If it was 1, that it meant no effect. If it was more than 1, then it meant that bacterial VP shunt infection were more common in the antibiotic-impregnated shunt group. So the overall odds ratio was 0.44, which can mean that if you use a standard ventriculoperitoneal shunt, then the patient will have 2.5 times higher chance to get a bacterial VP shunt infection. My second forest plot is also about infection, but I had 2 subgroups here. So the first subgroup was all the children, and the second only those articles which contained only the adult population, so no mixed population here. And the overall odds ratio was in the children subgroup 0.38, which shows us a tendency that in children it can be even more effective to use an antibiotic-impregnated VP shunt. My third forest plot is about shunt failure in a mixed population. Here I contain 9 articles. 3 of them were randomized control trials and the other were retrospective cohort studies. Here the overall odds ratio was 0.73. Behind this, the reason can be that if you look at my forest plot, for example, in Atanello's article, the odds ratio was 0.34. In this article, they only contained children who had an elective surgery. And for example, in Wong's article, where the odds ratio was 1.27, here the patients were adults with an urgent surgery because of hemorrhage, infections, and trauma. And also the adults had more risk factors like steroid treatment, hypertension, or other ongoing diseases. And also we think behind this result that there are other reasons which can lead to shunt failure, like hemorrhage and peritoneal adhesions. So to conclude, we would still suggest to use antibiotic-impregnated VP shunts because the most common reason of shunt failure is still infection. To summarize, the strengths of my analysis that I had a large number of patients, the articles were written in 9 different countries, and the limitations are that I only had 4 randomized control trials, and as you can see on my second forest plot, there was the absence of detailed age grouping in some studies. So our conclusion is that antibiotic-impregnated shunts decrease the rate of bacterial VP shunt infection to about 1/3. And the implication for practice is to use antibiotic-impregnated VP shunts. And the implication for the research would be that more randomized control trials are needed to investigate also the shunt failures, and adults and children should be investigated separately. So my manuscript was published in this year, May, in the Journal of Neurosurgery, which is a D1 journal. And I would like to continue with my second project, which is about defining the optimal and personalized dose of oral selumetinib in children treated with plexiform neurofibroma. So neurofibromatosis type 1 is an autosomal dominant condition, which is caused by the pathogenic variant of neurofibrin 1, which is a tumor suppressor gene. Plexiform neurofibroma only occurs in 5 to 15% of patients with NF1, and it can cause, in some cases, extreme pain. Selumetinib is a MEK inhibitor that we can use in this disease, patients with plexiform neurofibroma, and we also use this treatment at the pediatric center. Our problem is that we don't have so many available data about the pharmacokinetics of MEK inhibitors in children treated with this disease and plexiform neurofibroma. That's why our aim was to define the optimal dose of oral selumetinib in these children to reach an adequate blood concentration without toxicity. So we included the children treated with neurofibromatosis type 1 and also plexiform neurofibroma or optic nerve glioma. And the outcome was the exposure and pharmacokinetic characteristics of selumetinib in blood. And we hypothesized that oral selumetinib dose needs to be personalized based on drug monitoring. So our clinical implication would be that we would like to provide recommendations for the optimal selumetinib dosing to reach the optimal drug level without causing toxicity, and we would like to do it based on our drug monitoring. We included all the children under 18 years old who have neurofibromatosis type 1 and also plexiform neurofibroma or optic nerve glioma. And to reach the steady state, the inclusion criteria was that they needed to take the oral selumetinib therapy at least since 1 month. Our only exclusion criteria was that children who take other oral targeted therapy, they cannot be included in our study. And I would like to show you our pilot study. We already measured the drug level in 20 children between 5 and 15 years old. Their body mass index was between 14 and 22. And we observed side effects at 80% of the patients. I just put here the table to see that we take one blood sample before taking the oral selumetinib, and at this time we also check the kidney and the liver function, and also the blood count, and the other times, so we are putting a peripheral canal for the patients not to take so many times blood from them. And at the second, third time, we are just taking a small sample to measure the drug level. And I put here these curves to show you the importance of our study. So if you look at the patient number 3, you can see that the peak level of the therapy was reached like half an hour after taking selumetinib, and the elimination was really fast. But in the case of the patient number 1 and patient number 2, the absorption and also the elimination was much more slower. So these big differences can be in children. And I also put here, I know it's a lot of data, all the measured values in these 20 children. And from this slide, I would only like to highlight it that, for example, the area under the curve, in case of the first patient, is around 2,000. And in case of the last patient, it was more than 22,000, which is 10 times higher. So this is why we need that it has a really huge importance to do this therapy based on the drug level monitoring. We are planning to finish our project at the end of October. And I would like to thank you for your attention. And my favorite quote is from Kurt Vonnegut: "Science is magic that works." Thank you.
The second study, I think it's a small molecule, isn't it?
Sorry?
This is a small molecule. So it might be a subject of drug metabolizing enzyme activities. Did you consider to do a genotyping for the major, is it known which enzyme is involved in the metabolizing process? Because that is most likely due to a genetic variation in patient number 3, I guess, who is a poor metabolizer, maybe.
Yes, we were also thinking about that. I cannot tell you exactly the enzyme, but we were thinking a lot about it because we are working together with 2 pharmacists, and we were thinking a lot about this, that why can be so huge difference is maybe the food intake, maybe their body mass index, but the most possible is that based on their enzymes and their differences in their gene pool. But I don't know exactly which enzyme.
Thank you for the presentation. I would like to ask about your first study. That what was the antibiotic given to these patient populations? Was there any difference? And if there was, have you done a subgroup analysis based on that?
So thank you for your question. Basically, there was a protocol which was published, I think, 2 years ago from the Hydrocephalus Association. And I was really surprised because in this protocol they wrote about that you should shave the hair of the patient there, you should use chlorhexidine or povidone iodide there, and you should use, the surgeon should use double gloves and give preoperative antibiotics. But I was reading through the text many times and they didn't define that what antibiotics should be given in the protocol. And they were doing not an audit, but they were checking in a lot of centers whether so how was the adherence to this protocol, and they only measured if they gave preoperative antibiotic or not. But most of the studies, in this meta-analysis, they gave some kind of cephalosporin, for example, cefazolin, ceftriaxone, or cefuroxime. But in case of adult population, in 2 articles, they gave ampicillin sulbactam. And also there was 1 article which contained some kind of cephalosporin plus vancomycin. And what is also interesting for me that the postoperative treatment, it's not the same at every hospital. Some places they continue only for 1 day, some places for 3 days, and at some place for 5 days. And as far as I know, the Hungarian protocol is that they are continuing the postoperative treatment for 3 days, and they gave cefazolin. But so discussing the subgroup analysis, in some article, they didn't even mention that what kind of antibiotic they gave. They just wrote that, okay, we gave the preoperative antibiotics. So that's why it was not possible.
The conclusion of your first paper, so more RCTs are needed to investigate kind of the shunt failures issue. What would be your favorite RCT or RCTs you would design to address this study question?
So there was in the 27 article that I was analyzing with my group, so there was a really excellent article, a British article where they counted more centers, and it was 3-arm randomized control trial. In 1 arm they used the silver impregnated antibiotic shunt, in 1 the antibiotic impregnated shunt, and in the 3rd the standard VP shunt. And I think that this would be the best method, but it's need a large population. So that's why I think that only a multi-center study would be worse to do to analyze these patients also with the shunt failures. And what I would also like to tell that in some papers they wrote that, okay, we experienced the shunt failure, but they didn't really detail that what was the reason. So from the 9 articles, there were like 2 articles where they didn't include. So that would be much more helpful if they would write down everything precisely, because...
What actually, sorry if I missed, what is the standard of treatment? So non-antibiotic impregnated, is it kind of, can it be used as a standard comparison group?
So based on the new protocol, for all the pediatric patients, they are suggesting to use the antibiotic-impregnated ventriculoperitoneal shunt. But in case of adults without more risk factors, they still use it. And also in case of children at some places. So, but this would be the standard, that in case of pediatric patients, use this antibiotic-impregnated shunt.
Considering this heterogeneity, was the definition of shunt infection the same in all studies?
Thank you, Petra. So in most articles, so the baseline was that all the patients had clinical symptoms like headache, vomiting, fever, lethargy, neck stiffness, sometimes abdominal pain. And I would say that 80% of the article was considering only as a shunt infection if there was a positive microbiological culture. So it was also different because in some cases they took the sample, I mean every case they took sample from the cerebrospinal fluid, but in some articles they also considered as a positive culture when they when they removed the ventriculoperitoneal shunt and they sent the shunt to the microbiology, and when this culture was positive, they also considered it. I only found like 1 or 2 articles where it was enough that they had the clinical symptoms and the cerebrospinal fluid. In the cerebrospinal fluid, the white blood cell count was high, the glucose level was low, and it was enough without a positive microbiological culture. But most papers had an adherence to this.
Okay, thank you. My question would be regarding your second study. You mentioned that the majority of the patients experienced side effects, and I'm just wondering what were the most common ones you observed?
Thank you. So luckily, these side effects were not so severe. So mostly they had nausea, abdominal pain. They had a higher level of creatine kinase enzyme. And what was also really common, that they had a nail inflammation and nail infection. But it was really uncomfortable and painful for them, but these were the most side effects.
You showed really different AUC curves, and was there a link between the drug level and the side effects?
Thank you for your question. So I would say not exclusively, because in case of the peak concentration was high, they had some side effects, but it happened also that the peak concentration was half of the highest one, and the child also had a side effect, but this would also be one of our questions, that whether we can do the clinical relevance based on this drug level monitoring, because we would wait that, yes, if it's higher and if the elimination is slower, then they would have more side effects. So we are working on it, but not totally relevant. There is no association between that strictly.
How hard it was to obtain the, the parents when they are hearing that blood need to be taken from the children. It's something that it's not easy to convince them that it's a good idea. How hard it was to get the approval for the second project?
Thank you. So first, what would be my answer to your question? That what helped us to convince them that when they are coming for the usual checkup, we are taking blood anyway. So we need to check the blood count and also, for example, the creatine kinase level, because I told that it can be elevated. And basically what is important mostly for the parents, as far as I saw, that one time, they are putting one time a needle. It doesn't really matter them that maybe it can be uncomfortable if they leave a peripheral cannula there, but I thought that it's only gonna be one time pain, after that a bit uncomfortable, and like that it was easier to convince them. And also we selected the patient that first we started those one who live here at the city center and are older, because they need to sit there for 6-7 hours to take all these blood samples. And then we continued with those patients who are also older but live a bit further. And then our third wave was those patients who are around 5-6 years old and live further. So we still have some patients in whom we can measure the drug level, but I think that they were cooperating good.
You mentioned this RCT of your first project with the 3 arms. That was really, really good. What was the result of that RCT and the other RCT?
So it was Malucci, and I think that it contained twice, because one we measured the outcome in the pediatric population and one in the adult population. So I think that in the adult population it was 0.98, and in the pediatric population it was 0.36. So we could see a tendency that also in this case it was more effective. It showed a tendency.
Okay, and there was another RCT, right?
There were 3 other RCTs.
Oh, okay.
So it was one from Heller. It was 0.74, and this article also contained adult population. And one from Govender, it was 0.32. Here there were neonates in the population.
But the RCTs are not on the extreme of the figure. That's the idea, right? So the RCTs are not on the extreme of the results.
No.
And please excuse my ignorance. I have no idea what I'm asking or what I'm listening to from the clinical aspect. But I have a very outsider question. Is there a disadvantage to using the antibiotic-coated shunts?
Yes, so in some article, they were also examining that if the microbiological culture was positive, that whether they were resistant to these antibiotics, what was put into the clindamycin and rifampicin. And no, they didn't see so many side effects, so there were no
Is it more expensive or?
4 times more expensive.
Okay, that's the disadvantage then. Okay,
yes.
Okay, thank you.
Are you ever aware of any cost-benefit analysis studies on this regards? Because I think probably it would decide.
Thank you. So we couldn't do a proper analysis. We found 4 articles in which they were talking about the hospitalization-related cost and also the cost of this treatment, but so the measurement was not the same in the 4 articles. So we couldn't compare it totally statistically, but we saw a tendency that yes, at the end it was more beneficial. But only in these 4 articles. That's why I don't have a forest plot about it, because.
Regarding the second trial and about the graphs which are representing the differences of the metabolism or the pharmacokinetics. So sorry, but this is a critical comment that the scale of the concentration is 3 different scales. One is a logarithmic one, the other is a non-logarithmic, and the third is without. Could you see?
Yes, I can see.
Okay,
yes,
it would be
yes,
so nice
now.
to present data on the same scale, just to make comparison easier to the audience.
Yes.
Okay, in the future.
Yes, it's still a pilot study.
Yeah, okay.
We will have a meeting soon with the pharmacists to take also the clinical interpretation.
Got yesterday the data, the first. Have you got yesterday the data, data? No, okay.
No.
So in the future it would be nice to present it on the same scale. The other is the conclusion of the first trial, the systematic review that. So, is anybody read a paper, a systematic review that no further RCT is needed to answer the question?
We are done.
Oh, yeah. Probably this huge effect make so it allowed to draw such a conclusion. This is one, and the other is that more RCTs are needed about so adults and children should be investigated separately. In the group of children, probably newborn or preterm infants, need separate studies based on your opinion?
So we didn't include preterm infants, but I think from my studies that there would be huge differences because preterm infants have much more risk factors than term infants.
So probably this rate of shunt infections are even higher. Great. So we need studies. Probably here in Hungary we can perform one. Okay.
Yes.